I'd like to acknowledge the traditional custodians of the land we meet on today, and I'd like to pay my respects to elders both past and present, and would like to extend that respect to other Aboriginal and Torres Strait Islander people here today. I'd also like to acknowledge birthing practices involving recognising the spiritual and cultural significance of the land where a woman gives birth. This practice is deeply rooted in the traditions and knowledge of Aboriginal and Torres Strait Islander peoples who have a long history of birth on country. Now, I've worked at this hospital since I was an SRMO in 1994, and it's quite possible some of you may not have even been born then. And I became a consultant obstetrician in 2002, but I think they've only invited me here today in my capacity as the Director of Obstetrics, which is a new role I commenced in July this year. You've probably all had dealings with Andrew Bissett, who retired at the end of June from his full-time role as Medical Maternity Co-Director, a role he fulfilled for 15 very busy years. His are extremely large shoes to fill. And we have been fortunate enough to have one of our obstetric physicians, Helen Barrett, capably take on that role part-time since July. However, Helen is sadly finishing with us at the end of this week, as has an opportunity to move to greener and warmer pastures in Queensland, and her replacement is yet to be determined. Mine is a new role and I only work 2 days a week, so as you can appreciate, there's much ongoing change in medical leadership at this hospital, so watch this space. However, change always gives us an opportunity to reflect and grow. So not only is there change in our medical leadership, but in particular with the New South Wales Birth Trauma Inquiry, greater acknowledgement of patient-centred care and shared decision-making, it has become clear that women want options of models of care for pregnancy and birth, and ideally continuity of care. Within the resource limitations of a public hospital, we are keen to offer as many feasible models of care, and GP shared care has always been one of them. As there are more models of care and there is a declining birth rate in this area, fewer women are currently registered in the GP shared care program, but for women who already have an established and trusted relationship with their GP, this is their preferred option. As most pregnant women are in their 20s and 30s, or around here in their 40s, we do find many women come to the pregnancy without an established relationship with a GP, and I think that's particularly common in urban areas. But pregnancy is a perfect time, therefore, for them to establish a relationship with a trusted GP, someone who's going to care for her and her growing family well beyond pregnancy. And we all know having a long-term primary care relationship with a known and trusted GP is essential for ongoing optimal health. Even if a woman is not attending you through the GP Share Care program, I'd also like to thank you for helping us support many women through their pregnancies. It is you they see to diagnose and confirm their pregnancy and help them navigate through those first few weeks of tests, nausea, uncertainty, where to have their baby, and you help them with the booking process. We acknowledge you also see them for many non-pregnancy related issues during their pregnancy. You administer the recommended vaccinations and you care for them postnatally and beyond. So thank you. We have some great speakers today and I hope you gain something from that. And if there is a tea break, I look forward to catching up with some of you then. Thank you very much.
So sorry, you told me to turn it off. I'll turn it too echoey. I'll turn it down. Yeah. Okay.
I can enunciate. All right. All right. Thank you, Dr. Wendy Hawke. My name is Dr. Ezra Malouf. I'm a GP advisor and I'm facilitating today's event with Dr. Zarin as well. So welcome again to the Obstetrics and Gynaecology update. We also welcome everyone who is participating online. So we're going to start with the housekeeping before the afternoon program. So number one, bathrooms are located on level 0 and level 1 upstairs. There will be signs. Fire exits on level 0 down here. Follow the staff in the event of an emergency. We request that mobile phones are switched off or turned to silent mode. If you need to take a call, please do so in the foyer to not disturb everybody. We also ask no food is to be eaten in the lecture theatre. We are pleased to present a comprehensive program this afternoon. In the interest of keeping to time, we request that you reserve asking questions till the end of each presentation. Please keep in mind we do have a lot of attendees here and online, so keep your questions succinct and be mindful of others who might wish to ask some questions. For those online, please ensure that you submit your questions to the speakers in the Q&A function throughout the presentation. At the conclusion of the event, it would appreciate it if you could complete the evaluation form. There's a QR code included in your information packs. And for those online, the evaluation survey will be sent by email as well. We appreciate your feedback. Please complete this to allow us to issue the certificates of attendance. Now, CESPHN greatly appreciates the support of our sponsor for today's event. We have 3 fantastic sponsors with us today. We have Besson's Healthcare, Randwick Women's Imaging and Ultrasound Care. Please take a few moments to chat with them during the break. Please note a record of your attendance will be passed on to the sponsor. The only information provided is name and name of your practice. If you do not wish to have a record of this passed on to the sponsor organisations, please identify yourself to the CESPHN staff at the registration table and they will remove you from the list. Today's session is RHCGP approved for 2.5 educational hours. These will be uploaded to your dashboard after the activity. There's 6 ANSC points are also allocated. Remember, it's 12 a year, so just going to try 2 of these. The remaining events for the year are on the CESPHN website. Please register online. A reminder that the ANSC CPD requirements have not changed, and this year is the last year of the triennium for ANSC. So you need to have the 12 ANSC points to remain accredited, and contact the team at ansc@cesphn.com.au, and the calendar of events is available next year. That's housekeeping done. Now, I'd like to introduce our first speaker for today, Dr. Amanda Beech. Amanda Beech is an obstetric medicine physician and women's health endocrinologist at the Royal Hospital for Women and a conjoint senior lecturer at the University of New South Wales. She's the current president of the International Society of Obstetric Medicine and sits on the education subcommittee of the Society of Obstetric Medicine of Australia and New Zealand. Please welcome Dr. Beech.
Oh, thank you. So how's that for sound? Does that sound okay? Okay, perfect. So I am going to talk you through the nice and simple updates on the new gestational diabetes criteria. So luckily there are only 4 things that you need to remember by the end of my talk today, and hopefully I will take you through it in the next 15 minutes, and we'll have a little bit of time for questions. So my only disclosure this afternoon is that I have previously received speaker honoraria from BSAN in the sort of menopause setting. So we all know that that pregnancy is a diabetogenic state. So the idea of a pregnancy is really to, well, not the idea of a pregnancy, but the diabetes state of pregnancy is because what we're trying to do is encourage the glucose across to the fetus. And so the insulin resistance, the hormones of pregnancy that are secreted by the placenta make women more insulin resistant in their pregnancy. And because of that, we know that the blood glucose levels change, the postprandials increase as the pregnancy progresses, and that's why we picked 28 weeks to do our oral glucose tolerance test, early enough for us to discover that they do have underlying hyperglycemia, but early enough for us to intervene so things don't go pear-shaped. And this is my only real research slide. The landmark trial around this was the HARPO study. And the HARPO study was the reason that the ADIPS criteria in 2014 were developed and the IAD-PSG criteria. So essentially what they looked at was oral glucose tolerance tests in women who were pregnant untreated, so they just did the oral glucose tolerance test and then looked at various pregnancy outcomes. And you can see, I'll see if I've got a little pointer here. You can see that as the glucose categories increase, so these are not actual glucose levels, they're just categories of sugar, as the glucose categories increased, so the frequency of all of these adverse pregnancy outcomes increased. And the biggest problem here is that there is no inflection point. There's no point at which there is no risk other than obviously not having a pregnancy. So the problem is that wherever you pick your sugar levels for fasting for 1 hour, for 2 hours on the oral glucose tolerance test, you're always just balancing your risk. There's no point at which underneath there would be no risk. That would have made our lives a whole lot easier. We would not have this constant discussion. So what are the pregnancy risks? Super easily, there are maternal and neonatal risks, with the maternal risks around hypertensive disorders in pregnancy, an increased risk of cesarean section, preterm birth, and of course, most importantly to the endocrinologists, the long-term risk of type 2 diabetes and the metabolic syndrome. And then of course, there are fetal risks. So the increased risks of large for gestational age or macrosomia, just like this cute little baby, shoulder dystocia, neonatal hypoglycemia and respiratory distress resulting in NICU admission, and increased hyperbilirubinemia. So why have things changed? I'm clicking on the wrong button. Why have things changed? Is that better? No. All right, how about that? Great. All right. So what has changed and why have we moved away from the 2014 ADIPS criteria? So very simply, there have been a couple of new trials recently that have made us question whether or not the original cutoff that we picked in 2014 was the right one. And those two trials, one was done in New Zealand and it looked at low versus higher glycemic targets. And what that showed is that the lower targets, which is what we were following up until September, that the lower targets increased the risk of, the use of hospital resources, the use of insulin, the use of metformin, but it also increased the risk of neonatal hypoglycemia. So there was a question as to whether we were actually doing some damage or adversely affecting the baby. And then there was the toboggan study, which was published a year or two ago now, and that suggested that really where the majority of adverse outcomes stem from is in the first trimester or in the early part of pregnancy. The women who had the greatest risk for adverse pregnancy outcomes with those identified early on. And so these two trials, plus a couple of other things, really made ADIPS wonder whether or not we might need to think about changing the cutoff criteria. So if you have nothing to do tonight when you head home after this exciting and stimulating afternoon, I would recommend picking up this fantastic consensus recommendation. It's a riveting read, but if you don't have the time to do that, we have summarized it for you in a very simple flow sheet, which I think you've got a copy of. No? Okay, well, I want to say, first off, this has not been fully ratified across the LHD because we are still debating 2 risk factors. But the rest of the flow sheet is that the flow sheet that we would really recommend that is followed. And I'm going to take you step by step through it. So the 4 things that have changed. The first is that there is now a new definition when it comes to diabetes in pregnancy. So gestational diabetes on its own has not changed. It's still hyperglycemia in pregnancy, but there is now this definition of overt diabetes in pregnancy. So if a woman has a fasting glucose greater than or equal to 7, a 2-hour glucose greater than or equal to 11.1, and an HbA1c greater than or equal to 6.5 at any time in the pregnancy, they receive a diagnosis of overt diabetes in pregnancy. And this is so simple because this is the same diagnosis for diabetes outside pregnancy. So it's not too much of a stretch. So you can see from the first part of our guideline that if the woman presents with any of those, they should be referred directly to the diabetes service or to our diabetes educators, because by nature of the overt diabetes in pregnancy, they are going to need more follow-up. So the second recommendation that has come out of these new criteria are for the GPs or anyone who's doing the early first trimester antenatal bloods to no longer do a fasting blood glucose. So blood glucose in the first trimester is out and HbA1c is in, but only for the cohort of women who have risk factors. And as I mentioned before, we're still debating all of these, but these are our previous risk factors that have been well and truly adopted, and you'll all know very easily. I actually can't read mine. So if I look up there, yes, ethnicity, all the usual things, ethnicity, race, BMI, age over 40, previous GDM, family history, etc. So if a woman is seeing you in your consulting rooms in the first trimester and she's sent off for bloods, and she has any of these risk factors, we would recommend that she has an HbA1c as part of those first trimester bloods. So any risk factor, perform the HbA1c, and then if it's greater than or equal to 5, well, she gets the overt diabetes diagnosis. 6.5, sorry. If she's greater than, if she's 6.0 to 6.4, she gets a diagnosis of early GDM without having to proceed to a pregnancy oral glucose tolerance test. We know how much women do not like their oral glucose tolerance tests. And so in this case, if she has an orange traffic light, she has a diagnosis of early GDM. Sorry, something's happened to my square. And she gets referred directly. So those women do not need an oral glucose tolerance test. Thirdly, the simple one, these are, remember, women who have risk factors. If their HbA1c is less than 6%, they still have risk factors, and so they need an early oral glucose tolerance test. Also, there, of course, will be some women who have been missed, who haven't had an HbA1c with risk factors, and then they also need the early oral glucose tolerance test. So the third thing that has changed for us is the new diagnostic criteria. So the fasting has increased from greater than or equal to 5.1 to between 5.3 and 6.9, remembering that 7 or over is overt diabetes. The 1 hour is no longer 10.1, it's now greater than or equal to 10.6, and the 2 hour is no longer greater than or equal to 8.5, but it's 9 to 11. So those are the new criteria. They are slightly higher. So if we remember our HARPO risk, they're going to denote a group who are at higher risk, but we still don't know that we're 100% right in doing this. So we're going to be very closely watching and auditing our women over the next couple of years, as are many hospitals, to see whether or not this change helps. We actually think it's going to reduce the number of women diagnosed with gestational diabetes by about 40%, which is quite a big number. So as I mentioned before, those who have an HbA1c in the green zone, so less than 6, plus risk factors, or those who didn't get an HbA1c, they need to have an early oral glucose tolerance test. And based on the data from Terrific, the recommendation is 10 to 14 weeks. Now, this is going to be very difficult because lots of our women are not going to tolerate an oral glucose tolerance test at 10 weeks. So if at all possible, if they're feeling well, they should have it done between those gestations. But if they still have nausea and vomiting in pregnancy, they need to have it done before 20 weeks with the same diagnostic criteria I mentioned before. And the last thing to say is, for those who have no risk factors and those who have passed their oral glucose tolerance test at 14 weeks, they then go on to have another one at 24 to 28 weeks with the same diagnostic criteria as we had before. So it's the simplest of flow sheets. I would recommend having, once we publish this, having it laminated in your inbox. I do. We have them in all of our antenatal outpatients. It'll take a little bit of time. But the most common question GPs ask me is, well, how do I explain these changes to my women? You know, half of them say, well, I was GDM in the last pregnancy and now I'm not. How do I explain this? And the way I explain it to mine is I just say, there's been a little bit more data where, you know, we think maybe we might have been diagnosing people a little bit too liberally before. And so we're trying this, we're trying something else, but we're going to make sure that we're doing the right thing. That's the end of my talk. So I'm very happy to take some questions. Yes. The most important box on all the coloured boxes is this yellow box down the bottom. So if you are concerned that the woman may have any suspicious features of gestational diabetes, then refer to us, because we can do finger prick testing, we can do increased fetal monitoring. Because we're not 100% sure that these are the perfect criteria, we will need to be watching our women very, very closely over the next couple of years. And so if you're worried, if there's a clinical suspicion, please refer them to us, because we will take that on board and make sure there's more monitoring. Dr. Coogan.
With the new criteria, how many antenates are going to be diagnosed as GDM?
So 40%, how many antenates? 40% less. So we have about 350, 400 a year. Yes, so no women who's had a history of gastric sleeve surgery should be having an oral glucose tolerance test. They don't tolerate it very well at all. It's a very good point. They don't tolerate it. They get severe postprandial hypoglycemia. They often vomit. And so no, we wouldn't be doing oral glucose tolerance tests for those women. They may well be at risk, and so they should get that early HbA1c. If it's normal, so if it's the green box up there, they should then be referred to us or to the diabetes team to have a week of finger prick testing. Yeah, perfect. So the GLP-1s are a tricky one, so we would prefer that they're not on them in pregnancy. Obviously, it does slow gastric outlet and that sort of thing. So for most women, it's not going to have an effect if you're doing it at 6 or 8 weeks in the pregnancy. And by the time they get to their pregnancy oral glucose tolerance test, it's not going to have that much of an impact. Absolutely. So they actually were more on board. So the question for those in the audience was, do the pathology providers know? They were actually more on board than we were. So they started the change in August, and we only got to the change in September. So yeah, so they were ahead of us. Any other questions? Are there any online questions?
Yeah, there are some online questions. One of them was, is there any role for fasting glucose and HbA1c combination for women who can't tolerate OGTT?
The question is, was there any role for fasting glucose and an HbA1c in women who can't tolerate the oral glucose tolerance test? We were doing it during COVID, and what we discovered was we actually missed a fair number. And so no, that's not the recommendation these days. If they can't tolerate it, then we would get them to come and see us for a week of finger prick testing. That's a lot better for us than CGM. So there's a lot of CGM preference in the community, but we actually don't have good validated data around CGM in the gestational diabetes space. The interstitial fluid is different. So what that measures is a different glucose level than what's measured in finger prick testing, and we've got no data around that. So it's likely to be an evolving space, but it's not something we should do now.
There's also another online question. Does this change how we follow up women who were previously diagnosed with GDM postpartum but may not have met the current criteria?
So I would still, because we don't know, because we have no outcome data on these new criteria. So what we've got is a general thought from a particular group that maybe this is, maybe we need to change the criteria, but we don't have good evidence, whereas we do have very good evidence of an improvement in outcomes in women who were treated, who had a previous diagnosis of GDM. So I would still counsel women in the postnatal setting who have had a previous diagnosis of GDM that they may well have that they do have a future risk of type 2 diabetes. I would get them to do their screening regularly. I wouldn't change that because we're not 100% sure that we're doing the right thing. So yeah, I would still be testing them. And certainly I make them come back for their OGTTs at 11 weeks, 12 weeks. Any other questions? Any other questions from the audience? All right. Oh yeah, one at the back. As I mentioned before, there is no validation on the CGM. So I would say that should be actively discouraged. We also feel very strongly that where the data is around the oral glucose tolerance test. So that is the gold standard at this stage. We all know it's not a perfect test, but it's where all the data sits around safety. So that's how I counsel them, because we don't know whether a week of finger prick testing is actually inaccurate. Do you take one reading that's high? Do you use 20% of readings that high? No one's ever done the studies. So I tell women that the best outcomes and the best advice we have is related to having the oral glucose tolerance test. So
Yeah, so just that was the source related that we can overburden our diabetes educators with that. So that's where that came from. That will take women who can't do it for medical reasons, but not women who just choose not to.
There's one more online question as well. Can you get an HbA1c at 12 weeks if you miss it early? Can you get an HbA1c at 12 weeks if you miss it early?
Yes, so you could do an HbA1c at 12 weeks, but actually by that stage, our by that stage, our flow sheet would recommend an oral glucose tolerance test. It's useful if it's positive, because then they can avoid an oral glucose tolerance test. But by 12 weeks, if she's not got severe nausea and vomiting, it's probably best just to do the OGTT if she tolerate it. All right, I think that's them. Thank you.
Our next presenter is Dr. Shelley Wang. Dr. Shelley Wang is currently one of the Royal Hospital for Women GP advisors, and she practices in Paddington. Thank you, Dr. Wang.
Hi everyone, I'm a little bit shorter, so I'm trying to not. Hi, does this work? Oh, okay. Oh, yeah. Great, thank you. So I'm here to talk about the upcoming changes to our GP shared care program. This is scheduled to be rolled in 12th of January next year. Thank you. Now, these slides, I believe you guys will have a copy of them after this, and it goes through everything, the entire protocol. I'm going to assume that you're well aware of at least the old protocol anyway, and I'm going to focus on the differences and also anything that I think is worth re-highlighting, because obviously no one remembers everything from our initial intake meeting, and there has been some other changes along the way, so I'll go through and nitpick what I present properly. So yeah, this is the summary of the schedule of visits, what used to be or currently is, and what will be. There you go. So these are the timing as it stands and who's seeing them. This will be how it is. So you're going to see, as it stands, we're already doing most of the first trimester care anyway, so that's not changed. But then there's going to be a big chunk that us as GPs will be dealing with the woman. We're not completely alone. We still have the midwives liaisons, we still have the birth unit, we still have every resource at our disposal. We can still refer them in for any extra clinics or help. But just letting you know, there is going to be a big chunk of time that's on us. Just highlighting that there is also still the anti-day clinics. So that's going to be done at hospital, but please highlight to your women that this is not a full midwives clinic. This is literally just, you need anti-D, here's a jab, back to your GP. The onus is still going to be on us for those times. The different modes of antenatal care. Now that hasn't changed, and with whichever version your patient wants to do, please still do the e-referral and just select under the mode of care what their preferred option is. I'll go through e-referrals in more detail later. Specifically, I do want to highlight midwifery group practice versus MAPS, because I know I personally had some questions about this to begin with. So both of these services are midwives-led, and to begin with, for your pregnancy care, you've got your set midwife, or at least group of midwives that the patient will be seeing. And then when it comes time to give birth, midwifery group practice, it'll be that dedicated midwife at your birth, but not MAPS. After giving birth, for your any out of hospital, home visits, etc., the midwifery group practice will not be that midwife doing those cares, but MAPS will. So essentially, the woman kind of has to choose, would they want their dedicated continuity of care midwife to be with them at their birth versus at home? The next automatic question everyone's going to ask is, why don't we have it all? Because we can't. Because if you're on call for births in the hospital, it's really hard to also be scheduling in home visits. And also it's a resource thing. Midwifery group practice is extremely resource intensive. So is MAPS, but to a different degree. These specialties also hasn't changed, but just wanting to remind everyone that for these subspecialty clinics, they need their own separate referral. So you would have put through one standard pregnancy e-referral for whichever of these shared care or midwifery practices. But then if you already know that they're going to be high risk, that there's going to be some other issue, please go ahead and put in a separate referral for whichever team you want involved. Here are yet more teams and clinics that you can refer a woman onto. Now, some of this will be through HealthLink again. Some of this won't be. Some of this will be a phone call or a fax or whatever. If you're not sure, please feel free to pick up the phone or email or text the liaison midwives. That'll be Chantel and Huilin, although I think for the next few months, Chantel is running away for a little bit, but she'll be back. More services. Have a look in them. They're great if you know that they are around. This is going through the aims and objectives of the antenatal shared care program. What are we here for? I'm not going to go through them in too much detail, but I do want to bring this back to why we're doing this change of our antenatal shared care protocol. Use of healthcare resources. I think there's been a degree, as it stands, of slight over-servicing from the midwives' clinics. So part of this is about pulling this more in line with what other networks are doing. But I think in the end, the difference it made is that women under GP shared care will be seeing the midwives for one less session than it currently stands. So it's actually not a huge difference. It's more about the order in which things are happening. And then, of course, continuity of care. As the GP, we are quite uniquely placed to provide that. And now with this new system, this new schedule, there's going to be those kind of two big chunks at the beginning and the middle that we'll be seeing them continuously. So hopefully there's going to be less back and forth. What happened last visit at hospital every single time we see them? Hopefully that will make things easier in some sense. Yes, it's going to make some of the things harder, but we'll go through that. Okay. What does it take to be a GP shared care provider with us? So you're all here, you've all applied, you've all been accepted, you've all gone through an intake meeting. So thank you for all of that. Please make sure that you keep us updated. So emailing through your medical registration, your indemnity, your CPD points, and also being committed to ongoing education, such as events like this. Specifically in terms of ongoing education, so we do have to be clinically current and up to date. So yes, that's your CPD requirements. As mentioned earlier, we need 12 points of antenatal or postnatal related events per triennium. And also with these antenatal care updates, the aim moving forward is to have all of us come to one of these sessions once every triennium. Now that could be face-to-face, that could also be virtual. And I think quite a few of us are actually attending this more than once every 3 years anyway, so we don't think it's going to be too much of an onerous task. But there's also other sessions available. So we've got the obstetric placements and the neonatal placements, which you're all welcome to book in for. It's just a matter of trying to find the right time. But we have the dates, I believe, will be published for next year, but we have the dates already. And our compliance review, just saying that we will be monitoring making sure that everyone is attending one of these sessions, and we'll keep track of who's attending what clinic, etc. New South Wales health policy guidelines. I'm sure we all love reading all of that, but in particular, there are actually a lot of really good clinical business rules on our website. So it'll be good to, if not know everything off the top of your head, which is impossible, at least know where to go about finding them. E-referrals. I've been asked to really highlight the importance of doing e-referrals correctly. So I think we're all basically doing e-referrals now because it is the only way to refer into Royal Hospital Women, shared care, and also other forms of antenatal care. It's getting looked through really quickly. So it's getting checked in every day. So if you're worried about something, feel free to give us a call, but also know that it is being checked up. Make sure that you gather all the relevant information before you submit it. And by relevant information, I'm talking about your initial history, your initial examination biometrics, blood pressure, your initial blood tests, and there's a comprehensive list of what we definitely want. The dating ultrasound will also be highly, highly preferable. It definitely helps with the triaging, and also discussing with the woman upfront all the potential different models of care, referring them to the website to highlight the differences, and then that way you can put it through. Just because you put through a preferenced model of care doesn't mean the woman is locked in, but it's always good to just have an idea to begin with. If you submit the referral too early, what happens is it gets really hard to triage. It just gets put on hold. And then you have to submit everything all over again anyway when you do get the information. So you might as well just wait and get everything in. Please refer to a named clinician. As it stands, the people we're going to be asking you to refer to would be either Dr. Stephen Coogan or Dr. Louise Fay. But this list is going to change. So the list will be updated with the updated GP shared care protocol. So please refer back to this list. So if you're referring them for kind of standard antenatal care, please use, as it stands, either Dr. Fay or Dr. Coogan, but there's also a Dr. Sarah Uwe coming on board. There's potentially going to be some shuffling. If you're referring to a specific subspecialty clinic, please refer back to this list as to who you are referring to. You don't need to worry about trying to allocate things fairly between people. It will be reallocated as need be, but please, please, please do not put through an unnamed referral. That makes things very, very hard logistically. I think I've probably discussed most of this. Yeah, just highlighting that if there's anything special or extra clinics, make sure you submit a separate referral for that. So it'll be 2 referrals. I guess in theory, women, if they're already at the booking in visit with the midwives, they can also be internally referred, but it just makes things a lot quicker and a lot easier if we're aware they're going to need that subspecialty involvement anyway, to go ahead and refer immediately as opposed to waiting for them to show up at hospital, God knows when that is. And yes, obviously the liaison midwives are always around to call, and if you fail to call through, there's SMS and emailing. I'm going to skip through some of this because I actually go through in more detail later. The yellow card is fantastic when it works. So that relies on the woman bringing it. That relies on everyone actually filling in all the different parts. And I think now, because there's going to be that they're going to get the yellow card with the midwives, and then there's going to be a big chunk of time with just us. Just make sure if the woman doesn't bring their yellow card at some point, you go back and fill in what you can at the next session, and failing that, print out your antenatal visits and give it to them, because otherwise they're going to show up at Royal Women's at 36 weeks with not much. Okay, so this is going through the first trimester. What, as the GP, are we expected to do? So as it stands now and will be, we're basically running the show at this point. So I'll go through some of it in more detail. Obviously, please go through a very comprehensive history, which in and of itself can take a really long time. So often you'll end up seeing the woman multiple times over this first trimester. But also, yeah, going through their biometrics, their targeted physical examination, referring them for blood. So there's the routine stuff that we would like everyone to do no matter the situation. And then there's kind of the bonus extras, which, to be honest, we're probably at least offering to everyone already anyway. So this talking about, do they want to go through the combined first trimester screening versus the NIPT plus a structural ultrasound? Do they want or need to do a genetic carrier screening? assuming that they haven't already done it in the pre-pregnancy. So in case you're not aware, that is now Medicare bulk billable once in a lifetime for any woman considering or is pregnant. Yes?
Which test do you want to do? The specific test to do with the 13-week blood test is obstetric carrier screening. They screen the mother's blood, spinal muscular atrophy, cystic fibrosis, and Fragile X. That's not reproductive carrier screening. Is that different? $700, 700 recessive gene testing. That's my fault. I sort of went through this. The other thing is part of that testing. The preeclampsia screen is now regarded as a routine test and has implications for ongoing treatment, particularly with respect to aspirin. So my apologies for that. We'll clarify that before it goes up on the.
There's going to be more talks after my talk about that as well, I think so.
Just to clarify for online people, we said that the preeclampsia screening is now supposed to be mandatory or more routine? Routine test. And when you're requesting the first trimester genetic that we have to order it. And when we're requesting the first trimester genetic screen, we have to write down cystic fibrosis, spinal muscular atrophy, and Fragile X.
Okay, so then we're going to talk about, well, we have already talked about the diabetic screening. Thank you, Dr. Beech. Consider low-dose aspirin. So as Dr. Coogan alluded, there's a bit more information about that coming up with the next few talks, so I won't go into too much detail. Rhesus negative women consider NIPT for fetal rhesus status testing. So this is a work in progress in the sense that we haven't actually incorporated it into our antenatal protocol formally. So at this point, it's very much up to you and the patient whether or not you want to pursue this for your women who are rhesus negative and have a partner who is positive or question mark or God knows. So the only lab that does it is Douglas Hanly Moir, and there is a cost of around $50 to that. In theory, you can start doing the test from 11 weeks. In practice, it might be that you're going to get an inconclusive result until a bit later. But I guess if you're going to do it, as long as you get the results in time for what should be your first anti-D injection, which is 28 weeks, then you're good. But if this doesn't get done, then automatically then the rhesus negative women will need their anti-D testing, which means booking into those clinics. And also, yes, referral for ultrasounds, please. Now, it used to be that I would give them this piecemeal, come do your dating scan, come back, do your 13 morph scan, come back, here's your 20-week morphology scan. Just because of the way the schedule is now, we will see the woman maybe 12 weeks and then maybe not again until they're 24 weeks. So we're going to actually ask everyone, please give your women your however many weeks morphology scan earlier rather than later. A lot of counselling involved during this first trimester. So I will talk about pregnancy vaccinations. So that's flu, COVID, RSV, Boostrix, as a bare minimum to at least discuss. And then also talking about food, exercise, drug and alcohol smoking, any psychosocial concerns. And then, of course, yes, please start the referral. Then it's off to the hospital. So their booking visits usually around 14 weeks. That's when they get the yellow card, and then they get another session at the 2021 week. I'm not going to go into too much detail, but suffice to say there is a lot of information. These are some huge, huge visits. They last a really long time. The woman will get a huge pack of information, and both physically and verbally. So as the GP, it'll be helpful for us to help reinforce some of that information with the subsequent visits. And also I see that 20 and 21 week mark is going to be tricky because nowadays a lot of sonographers refuse to do it too early, the morphology scan, I mean, which means we're going to be aiming to try to get the woman in for their morphology scan as close to the 20-week mark as possible. And then they're going to follow up with the midwives as close to the 21-week mark as possible. And hopefully there will be something available for them to go off, or failing that, the midwives will obviously try to chase that up. But we are going to have to see how this schedule works. But in the meantime, when we see them at the 24-week mark, I'm going to ask everyone to just double check, and maybe, or obviously we're all reading the report ourselves, making sure there's nothing amiss, and then asking the woman, hey, by the way, was this addressed last time? Or if not, have you had a follow-up phone call in regards to this, just to make sure nothing gets missed in terms of the morphology scan. But yeah, from the 24-week onwards, there's a chunk of time where they are hopefully only seeing us and not requiring any sort of extra hospital care. So at the 24-week mark, give them their blood test form for their roughly 26-week blood tests. So as default, everyone gets syphilis screening, another blood group and antibody screen, regardless of their rhesus or anything else. GTT, unless they're already confirmed diabetic, everyone gets a GTT at this point. I would also full blood count and have a very low threshold for checking people's ferritin levels, especially if they've had a past history of low iron, or if they've suffered from nausea, vomiting, dietary restrictions during pregnancy, they're feeling tired. Really, there's a lot. Then, yeah, that's right. Goes without saying, please write everything on the yellow card every visit. And then there's a lot of counselling. So back to the information overload that they would have received from Royal Women's in the previous sessions, just reinforce to them all the different resources available to them on websites, including booking in for their pregnancy classes. There's not just antenatal classes, there's also like breastfeeding, partners, there's all sorts of classes that they can sign up for, and they can have a look at all of that on the website, on the Royal Women's website. Birth unit number, just remembering to highlight to them, this is your yellow card, there's a birth unit number. After 20 weeks, please call them if you're concerned. Specifically, what we would like them to call birth unit for would be any suspected rupture of membranes. Please call. Unexplained abdominal pain, unexplained bleeding, reduced fetal movements, that's a big one, and also educating women on monitoring fetal movements, which obviously depending on their situation, first pregnancy, subsequent, placenta, anterior, posterior, whatever, it might be different, but just making sure that they are keeping track of what is normal for them and to know when to call for help when things start to go a bit down. And then, we then send them off to the bloods. They come back. Hopefully we have the results at the 28-week mark. We would then refer them on to whichever subspecialty service might be invoked at this point. So whether that's the diabetic services, the hematologist, the infectious diseases, whatever it is, please put through another referral. And the RSV vaccine, RSV vaccine can be done from 28 weeks onwards now. I think up until now, the hospital has been doing a lot of that, but now that with this new schedule, it is going to be more of an onus for us to do it. I'm sure if for whatever reason your practice doesn't have it, you can call the liaison midwives and they can sort something out for you. Anti-D clinic, actually I'll talk about that on the next slide. Sorry, vaccinations, just make sure if they haven't already had their Boostrix shot, which might be done by the hospital at the 21-week mark, make sure that you get it done at your practice, and also the flu, vax, COVID, and also tell them about all of their family members, all of their friends, their nannies. Please start getting the idea into them that everyone else needs their shot as well. The anti-D clinic, is not actually a drop-in clinic. You do actually still need to be booked in, but it's a very quick, easy clinic. And hopefully they would have been booked in well ahead of this 28-week mark. But when they do show up at 28 weeks, make sure that they have their 26-week bloods as well, just to reconfirm their blood group and antibody in particular. So it's great to have had their initial screening, but please do the next one and bring that in as well. We keep going. So then we start looking at them at the 32-week mark. We're still double checking, have you already booked in with your classes? We try to get women to have completed their classes by the 37-week mark if possible. And keep encouraging resources use. How to write a birth sorry, they've corrected here, how to write birth preferences. So that is, there's actually a fact sheet targeted for patients on the Royal Hospital for Women website. I think it's under the visitor/patient information, and then it's under pregnancy as opposed to birth, which could be a little bit confusing. But yeah, if you can't find it on the birth, look under pregnancy, and it does go through in quite a bit of detail what the suggested, what it suggests being incorporated into this birth preference. We try to not call it birth plan anymore. And then 34 weeks. So after 32 weeks, the woman should be seeing someone roughly every 2 weeks at this point. 34 weeks, it talks about low vaginal salt for GBS. We're not actually doing that. We're not arranging that. It's just a good idea to preempt the woman to say, hey, next time you go into the hospital, there's going to be a stick given to you or done. So just good to warn them. And I would also have a low threshold for any of my at-risk women to repeat their full blood count to 9 at this point as well. Back to Royal Women's. So the next big consult is at 36 weeks. Once again, a huge amount of information being given to them, potentially more referral pathways or more investigations. And yes, they get their GBS swab at that point. Then they see us, hopefully for the last time before baby's out. So I would use this 38-week visit to highlight to the woman, please book in your own postnatal visit with me at around the 6-week mark. Please don't try to squeeze everything in, because sometimes they think, oh, I'm here for the baby. I'm already booking a long consult for the baby. I'll show up then as well. Please try to get them their own separate appointment, because otherwise it's an absolute nightmare. Oh yeah, double checking that the yellow card is still around and you're filling all of that out. And any last minute questions, please feel free to divert to resources online. You don't have to explain everything to them yourself in person. And then they're seeing the hospital every week until baby comes. So that's more hospital visits. Resources for GPs. So the immunization handbook, it's not just about whooping cough, it's about so many other things. So please look into that if you're not already familiar. I forgot the mouse doesn't work. Lifeblood is a great, no, not going to bother. Lifeblood explains what the purpose of the fetal rhesus testing is. Unfortunately, Lifeblood, which is Red Cross, they don't actually do the blood tests anymore. That's only through DHM. But yeah, just giving you and the patient a bit of an idea of what it is. Genetics. Edu.au, that actually has a lot of courses for us to be able to do to help with our screening and our counselling. So there's apparently both paid and unpaid courses that you might want to have a look at. And then the Australian Pregnancy Care Guidelines, it's an Australian one thing, and it goes through everything, anything you might possibly want to know would all be there. I'm going to go back to the other slide. This is clinical business rules. So this is the Royal Women's specific clinical business rules. There's a lot available. There is a website listed down the bottom, so it'll be a good idea to bookmark that to your page if you haven't already. But what I find is if I just Google RHW policies, it tends to be the first link that comes up anyway, or it's pretty high up. And then when you do go into it, it has like A to Z up the top. But even before you click that, just that very first page already has some of it. It's a little bit unpredictable as to what's on that initial page and what do you have to click the sub letter first. So if you don't find it the first time, click on the letter for whatever topic you're thinking of. But it's most things are there somewhere. This is now more for patients, so links that you can direct patients to. pregnancy-birth-baby.org.au, that has a lot of information. It goes through like preconception all the way through to postpartum. There's also a book that's not listed here, so there's New South Wales Health Having a Baby, which is now available as a PDF. It's no longer being given out as a physical book, but women, I believe, get that link automatically. But they're both great resources which go through pretty much from pre-beginning to past and anything in between. saferbaby.org, that is a website that deals with a lot of kind of preventative things. So it talks about women sleeping on their side, how to monitor baby's movements for like information for the patient, talks about smoking cessation. So there's a lot of preventative stuff that if you want the woman to read a bit more about is great there. This CESPHN patient visitors fact sheets. So that's got a lot of information about pregnancy, and also that will be where you find things like how to write birth preferences. So that'll be a good website for the woman to have a look at. And then finally, this last link, childbirth and parenting education, that is how they can read up about the different classes available at Royal Women's and how to go about booking them in. And then there's lots of help. So, birth unit from 20 weeks onwards, feel free to give the woman that phone number if they don't already have it, and make sure they know to call them if there are any concerns. So once again, it's about any suspected rupture of membranes, reduced fetal movements, bleeding, pain, anything that you think is a bit more urgent, please go ahead. Otherwise, if it's not super urgent, there's the liaison midwives. So that's Chantel and Huiling. And Monday to Friday, if they don't answer immediately, you can leave a message, leave a text message, and they usually get back pretty quickly. And then there's also the registrars, but admittedly, I tend to find when I call birth unit, they've already talked to the registrars on my behalf. So that's been very helpful. And that's it for my talk. I'll open it up to any questions. Thank you.
Can we have a copy of all of this?
Yes, I believe that's getting emailed out to you. And also please look out, because once the final protocol is finalized, they're going to be emailing this out as a notification through our newsletters. And just please keep an eye out on the updated PDF protocol as well. Oh, sorry, that question was, will you get this, a copy of this? And the answer is yes. Yes. It's a bit tricky. So the question is, if the midwives are automatically following up morphology scan results, do we still need to manually write CC Royal Hospital Women on our forms? Is that the question? Yeah. I think okay, Chantel will talk to that.
Answer is yes.
I think it's still quite hard to really get to the hospital. So just try to copy every possible path to get that result in is the way to go. Yes? Yes, that's the other thing we would recommend is whether it's scan results, blood test results, email a copy to the woman directly as well.
Different pathologists pretty much run pregnancy on two different names, married name and the Medicare name. Okay, so we can put all that together, and I mean, it's a bit cause confusion because
So the question is, what if the same woman has seen, for example, multiple GPs under different names, married name, maiden name? What if you've got basically a few different results? The answer to that is yes, please batch them together. The more information, the more helpful. And then on the e-referrals, sometimes it lets you send those results through, but sometimes for PDFs, it just doesn't quite work. So then I would be recommending anything urgent, anything of note, put that in your referral details, and also make sure that the woman has a copy of the results so that when they are being seen at the booking in, they've got everything to show. The fact that they are different names, I'm not too concerned about, because as long as they can confirm it is them, we can work with that. I would assume that is correct. Please feel free to correct me. Yes, that's right. Medicare numbers, date of, huh? Yeah. Mm.
20 minutes.
So Medicare, when they do the blood test and they put the Medicare card on, they'll relate to it. It's all the pathology.
Yeah.
But online, we were just saying that it shouldn't be too much of a problem from the hospital side.
Sorry, I think that lady was first. Hi. Good question. So we also just found this out. This is something that the midwives do. Actually, I should get Chantel to talk about this. Basically, it's a breath test that ladies are offered this test for. I think it's supposed to be done routinely, but obviously logistically that's not going to happen. But anyone who's at risk, it's an offered test to see what their smoke exposure has been.
It's just we do it every appointment to measure the CO2, basically. And if it does read high, then we offer them resources on how to make it lower, basically. So like it can be, well, obviously smoking, but environmental factors as well.
This is in regards to the carbon monoxide testing that is listed, I think, in the 14-week Royal Women's. Yes, there you go, carbon monoxide monitor. So that's not something us as GPs need to be too concerned about. That should be getting done with the midwives in hospital.
There are some online. Did you have a question?
Yes, but we don't. They are all, they're not PDF. It's so difficult. So I don't know if we can get any tools, because really it has to, something has to be done, because you cannot make them in one. You cannot put them in one document. You cannot do a PDF with them. Can't even email them. Yeah.
The comment was that New South Wales Health blood test results do not get incorporated into the general community information very easily, which I agree with. Unfortunately, not much that can be done at this point. Please pass the message, is the message. And yeah.
There were some online questions as well. I think I know the answer to some of them, and I might ask an obstetrician for some. One of them was just to clarify that the MGP does do home visits. So good to know. MGP, it does do home visits, the scheme. Yeah.
We usually have a group of 4 or 5 midwives for each midwifery group practice. They often do have a nominated midwife that they see for most of their care, but any of the team are on call for their birth. Sometimes they won't get any of their team if the team is maxed their hours, and they will end up with a birth unit midwife. But a member of that team will always do their postnatal visits. It might not be their primary midwife, but they will.
There was something else on the online one about can we add on the specialists, what specialty they are on that drop-down clinic? Short answer to that is no, not yet, but we're trying to get that on. We'll see what happens. Another question was, are GPs expected to get the NIPT or first trimester screen done? The answer is yes.
Is it better on this?
I might speak in there instead. Sorry, so I said about a GP is expected to get the NIPT or the first trimester screen done. The answer is yes. And there was actually a question about the carbon monoxide monitor, which we've answered now as well. Maybe a question for an obstetrician would be about preeclampsia screening in the first trimester. What does it consist of exactly? Maternal PAPA or PGLF, or I can't remember what I've written down, but is there something else? How does the PET screening work in the first trimester?
There's always confusion about the combined first trimester screening and the nuchal translucency screen and the measurement of the PAPA, the PLIGF and the HCG as opposed to the NIPS screen. Nearly all the labs, if you request an NIPS and a PET screen, will be taking those serum tests to incorporate with the morphology scan to produce a PET risk. It is a recognised test. It's not 100% validated, but it's the best we've got. The importance of it is in a high-risk patient, and it's a bit confusing because I have seen people who are given a risk of 1 in 100 as being labelled high risk. That's actually about the background risk for every pregnant woman. So the importance of it is starting aspirin before 14 weeks. If you don't start the aspirin before 14 weeks, it has no discernible effect. Yeah. So what was the? Yeah. So when they do the serum tests, the PAPA, the placental lactogen, and the beta HCG, that goes into an algorithm with the mother's arterial uterine artery waveform and produces this risk. So if you you just have to write PET screen, NIPS and PET screen, and the lab will take care of it. The ultrasound service will take care of it.
Another question.
No, so in terms of, for you guys, and I understand this is really a vocation for you guys, it's a lot of hard work. Far and away, the easiest thing to do is to send the mother to an accredited ultrasound service. If you try and order tests on one day, get the scan done on the other day, and then incorporate all of this, it's a lot of extra work for you. The problem is that the good ultrasound practices charge like rhinos. It's true, they do. Well, they charge appropriate to their service. So ultrasound care, Sydney Ultrasound for Women, I think Randwick Women's Imaging, they will all do this. Spectrum does a good job, and they are probably the cheapest in the local area. But they will then take all the bloods, put it through the algorithm and generate a result that comes back to you. Does that answer the question? If you're trying to do it on your, I mean, I don't do it on my own, it's way too complicated. So is that helpful? That's a good point. So that's first pregnancy is a good screen. You've probably noticed there's aspirin bracket creep for every pregnancy now. Growth restriction, preeclampsia, diabetes, all this stuff. The only thing the aspirin is really validated for is the prevention of early onset preeclampsia. There may be some help with insulin-dependent diabetes in terms of growth restriction. There's very little positive evidence about preventing growth restriction in an otherwise normal pregnancy. So yes, if as a screening process they had they were admitted for preeclampsia, they got medicated, there's no reason you shouldn't start them on aspirin at 14 weeks.
The question for online.
Yeah. So, no, severe, I'm trying to keep this simple as possible, not making too many little pocket holes for you. But yes, you won't get into trouble for doing that. Everything's been cut up into smaller and smaller pieces. It's complicated for us.
There was another question.
And look, I sympathise with you guys. When I see a new patient, quite often after they've already seen one of you, I will actually book a 45-minute slot to go through everything. So if you're seeing them for the very first time, oh, I've got a sore throat. Oh, and by the way, I'm pregnant. It's like, oh, shit. So that blows your whole morning out of the water. Yeah. Well, little Timmy's cut his foot. Oh, and I'm pregnant. It's like, yeah, great. So I truly understand and appreciate the work you do and how much work it is. And we really do appreciate it. The hospital per se may at times seem to underappreciate the effort that you make, but we really do appreciate it. We know we're not great with the back and forth communication. We're always working on it. We would love to have a website where every antenatal path result could be dumped into. We've been working on that for at least 8 years. The reason is Prince of Wales has become very paranoid about its health data security, and they will not give us a dumping sort of server for all the results, which is of course ridiculous, but it's the way it is.
There's another question from online, if you don't mind answering that as well, Dr. Coogan, about the sensitivity and specificity for the fetal rhesus status as part of the NIPT.
That's a good question. So the test is fully validated. There are a few limitations. It needs a certain fraction of fetal DNA, similar to the NIPS testing, so around about 11.5 weeks at first. And recently I found out that the test is not validated beyond 24 weeks. Sorry, is it 28? I got one turned down at 24. Okay. All right, that's right. I ordered it, but she didn't do it. If they give you, the wording is very carefully put, as in it's very unlikely this person has a rhesus positive baby. That's the best you're going to get. You're not going to get a definitive answer. We still check every baby for rhesus antibodies after delivery, and we'd give anti-D if we needed to. But if it's not positive during the pregnancy, it's very reassuring.
I think the false negative rate's only about 0.2%, so it's pretty good.
And just added on, sorry, just.
I think it's about $50.
Can I ask a dumb question, please? Why do we need NIPT and the structural ultrasound? If NIPT is meant to be reasonably or as accurate as we believe it is, to exclude the common abnormalities. What's the purpose of that?
So an NIPT is a purely chromosome test for the 3 most common chromosome anomalies and sex hormones. It's got nothing to do with the structure of the baby. So the ultrasound resolution at 13.5 or 14 weeks now is astonishingly good. You can see things like diaphragmatic hernias, you can see cardiac lesions, you can see absent kidneys, you can see anencephaly. So those are the things. They're rare, but it's very worthwhile doing it. No, so the morphology scan has been a fixed point in time since I think we started doing ultrasound. And nowhere around the world is there consensus yet that we should be changing that. The sonographers have got a bit toey about doing it at 19 weeks. They all want to do it at 20.5 weeks, which is a bit annoying for us because it upsets the routines. It's quite possible with the resolution of scanning now and in tertiary referral scanning services, an 18-week scan would be fine. But around the world, the 20 weeks is just a fixed point in time. It also relates to the legal definition of a birth versus a miscarriage. So that was part of that fixed point in time. And the machines 20 years ago didn't have the resolution they have now.
One way I think that the one you do at 13 weeks, they like us to refer to as an early structural ultrasound, and the 20-week one morphology. They essentially are looking the same thing, but they just see a lot more detail at 20 weeks. So I suppose if you think in your head, the 13 one is kind of an early look at the baby to see if they can pick up any obvious major abnormalities. But at 20 weeks, they will see a lot more subtlety. Yeah, that's it.
One last question from about IMTD.
I was just going to say the 20-week scans are so good now, they can count finger bones. And you might well ask, why aren't we doing 3D scans at 20 weeks? Again, because there is no algorithm for it and there's no acceptable recognised standards for it. Obviously, if you can look at a face, you're going to be able to see clefts. If you can look at a back, you're going to be able to see spinal defects. But there's no role for that which has been approved as yet.
Question.
13 weeks because they do the ultrasound.
So the combined first trimester screen and nuchal translucency screen is still in use around the state because not everybody's fully qualified or has a lab available to integrate those results. I think PA is still using that as a contingency screening test. They do that first, and if they find an anomaly, they then do an NIPS. It's also cheaper and it's rebatable, whereas the NIPS is not. So it's very inequitable that women's health at that level is not properly funded.
Is there a shortage supply of anti-D?
No. Have you found that?
It was an online question.
No, there's not. We're also getting super layered with extra bits of paper. Consent for vaccines, consent for anti-D, consent for this, consent for that, almost consent for an internal examination. The paper load is just increasing all the time. Like our booking forms for a caesarean at this hospital went from 2 pages to 16 pages, plus another page which has just been added courtesy of the new director of obstetrics.
Okay, thank you so much. Thank you, Dr. Shelley Wang, for that chat, and thank you, Dr. Coogan, for answering questions as well. I do believe we now so we will see you all at 2:30. Thank you so much. Okay, everyone, thank you for coming back. Is the microphone on? Our next presenter is Dr. Joan Rikard-Bell. Joan is a maternal fetal medicine fellow at the Royal Hospital for Women. She specialises in diagnosing and managing complicated pregnancies. She cares for women with fetal growth restriction on an almost daily basis. With 2 parents who are rural GPs, she understands the importance of collaborating together to support families through these complex pregnancies and beyond. Please welcome Joan.
So Dr. Rikard-Bell has kindly given me 5 minutes.
Okay.
I briefly raised earlier on the difference between reproductive carrier screening and obstetric carrier screening. So reproductive carrier screening is under the college guidelines, should be offered to every couple preconceptually. It can be done through Douglas, it can be done through Natera. There's a very good service, Eugene Labs. The problem is the cost is anywhere from $400 to $700. If you do it as a couple, which is obviously the sensible thing to do, it's about $700 with Eugene. I'm not sure what it is for the others. Yeah. So they can test that huge panel between 450 and 750 conditions, recessive conditions. And most of them we've never even heard of. So obstetric carrier screening is the test that is done with the NIPS bloods, and that tests for cystic fibrosis, spinal muscular atrophy, and Fragile X, and sex chromosomes. Joan's just told me that test is being expanded, but it's still very early to reconsider anything else. So do you all understand the difference between those two? Obviously, someone comes in and we're sort of required to bring it up with them, and you can bring it up with them too. But if you do reproductive carrier screening, it'll take between 4 and 6 weeks to get the results back. And some people have already had it done, some people may not be interested, but I don't know what the obligation for antenatal GPs is to provide information about that testing. Yeah. Yes. Yes. So the Medicare rebate is part of the NIPS for the obstetric carrier screening, but not the reproductive carrier screening. Joan's also just given me a bit of extra information about CMV screening, which slightly differently to what I told you before, now appears to be part of a guideline as of a month ago, that pre-conception, every woman should be given a CMV IgG test. And she might be willing to address that at the end of her talk. Thank you.
Okay, so thank you for that introduction. So I'm talking about fetal growth restriction, which kind of is a very, very common thing that we see in maternal fetal medicine. I don't have any disclosures. I was asked to do some learning objectives. So essentially the idea is to define fetal growth restriction, recognise those key risk factors and preventative strategies, understand available screening methods, identify when to send for further testing, and also understand the general management principles. So first we'll start with some definitions. So small for gestational age, or SGA, is where the estimated fetal weight or abdominal circumference is less than the 10th centile. Whilst fetal growth restriction, FGR or IUGR, is a fetus that has not reached its growth potential. So this could be where the estimated fetal weight or the abdominal circumference are less than the 10th centile, or if there's reduced growth velocity, which in Australia we consider to be more than 50 centiles. So you can kind of see in that diagram there that I've kind of created. So the green line, which is kind of tracking below that 10th centile but still growing beautifully, might be an SGA baby, or it could be a growth restricted baby. But you can see in the blue one, initially baby started being a beautiful big size and then it's kind of tapered off. And then the pink one below is kind of has always been small and they continue to taper off. So they're much more likely to be growth restricted babies. And this is also why this trajectory over time is really important. So every time we see someone, we actually plot all of their ultrasounds so we can actually see difference over time. And so it's important to know that not all SGA fetuses are growth restricted, and some growth restricted fetuses are not SGA. And kind of how I describe growth restriction to patients and families is that, say at 24 weeks, I'm a baby and I go to my kitchen and I say, I'd really like a banana. The kitchen says, absolutely, there's your banana. I go away happy. 28 weeks, I then go to the kitchen and say, I'd love a banana and can I have a cheese toasty too? Kitchen says, absolutely, here you go, here's your banana and cheese toasty. I get to 32 weeks and I'm like, cheese toasty, banana, and I'd really love a smoothie. The kitchen says, I'm really sorry, I don't have a smoothie for you. And so that's when my growth starts to be affected. And that's why that comes with these complications. Some other definitions, so we put them into two main classifications. So either early onset, where it occurs before 32 weeks, and that accounts for about a third of cases. Typically, it's much more severe, so there's a much more likely to be small babies, more commonly associated with maternal hypertension or an underlying genetic condition in the baby, and then have a much higher risk of mortality, either before delivery or afterwards. The vast majority are late onset, so this occurs after 32 weeks. Typically, it's a milder growth restriction and maternal hypertension is much less frequent. And so why do we actually care? Well, it's super common. So it affects up to 10% of all pregnancies. So many women that we look after have this condition, which is why I see it so frequently. And it also has really important sequelae for the mum, the fetus, the neonate, and also in the long term for this baby. So the mum's going to have complications of the underlying disease. She's going to have preeclampsia and the sequelae that actually occur that's going to affect her lifelong. Premature labour, operative delivery, caesarean. The babies at a 2 to 4 increased risk of stillbirth. It's much more likely to be acidotic and hypoxic at time of delivery. And then once it's born, it's a neonate. It's got all the complications of prematurity because it had to be delivered because it was growth restricted. It's more likely to be acidotic in birth, at poor at delivery. It's going to have a low APCAR score. It's going to get admitted to NICU and it's going to have all those sequelae, hypoglycemia, hypothermia, polycythemia, neonatal death. And in the longer term, these babies have a lower IQ. They tend to have learning and behavioural problems. They can have major neurological disabilities, seizures, cerebral palsy, developmental delay. And there's this metabolic reprogramming as well. So those babies that were growth restricted are much more likely to get blood pressure, diabetes, heart disease, obesity in their lifetime. So it's a super important condition. There's 4 main causes. So the majority is placental insufficiency, which we also call uteroplacental, or it could be a structural genetic variation in the baby. It could be an infection, or it could be constitutionally small, what we call small healthy. The baby was always going to be small, but it's okay. And when we're kind of looking at how small are we talking and which ones actually have underlying pathology, for all babies that are less than the 10th centile, you can see there 70% are constitutional or small healthy. Only 30% have underlying pathology that's making them significant. Whereas those that are less than the 3rd centile, what we'd call severe growth restriction, you can see there only 20% are small healthy. 70% have some underlying pathology. And that's partly why in maternal fetal medicine, we see that babies are less than the 3rd centile because they're much more likely to have an underlying cause that we need to work out. So as you can see there, 50% uteroplacental when they're severe, and this has got to do with our placental development. So it's a little bit complicated, but you can kind of see normal placental development. When we're not pregnant, we have really thin, narrow spiral arteries. We don't really need them to build up endometrium every month that we then shed. But once you fall pregnant, the trophoblasts kind of invade into those spiral arteries. They kind of make them go to a low resistance, high flow circulation. But when that doesn't happen properly and they stay really narrow, they stay really high resistance, that's when we get issues. And that's when you get that impaired placental growth and development, you get a small placenta, and you get that imbalance between maternal angiogenic and anti-angiogenic factors, which gives us that risk of preeclampsia. So if we're looking at risk factors, first if we look at mum, so mum has risk factors from chronic disease. So if she's got pre-existing diabetes, she's got blood pressure, she's got renal disease, antiphospholipid, lifestyle factors like smoking, drug use. If she's a bit older, so advanced maternal age, which we consider over 40 years. And then we've got the uterine reasons. So if she's got large fibroids, if she's had uterine anomalies, or even if she's got like recurrent bleeds, that can also be risk factors. And then we look at the baby. So if the baby has a genetic variant, then that can cause it to be growth restricted. Or baby has a structural anomaly. That would typically be cardiac or skeletal, but really could be anything. If the baby's affected by an infection, or also if we have multiple pregnancies, so twins, triplets, quads. It can also be related to the placenta. So if the placenta has a genetic variant called a confined placental mosaicism, that can affect the growth of the baby. Or if there's an abnormality in the cord, so if there's a single umbilical artery or a 2-vessel cord, or velamentous where the cord, rather than inserting in the middle, kind of inserts to the side, a low PAPA, which we tend to get on that early structural scan, so we consider less than 0.4 to be significant. If there's something else wrong with the placenta, so chronic abruption, so little separations of the placenta that's going to affect its function. If there's an infection in the placenta, infarction, so areas of it's not actually working, or if there's a placental tumour. And kind of all of these risk factors go into this diagram you may have seen before. So this is the New South Wales Health Fetal Growth Restriction Care Pathway, which was kind of created by the CEC and the Safer Baby Bundle. And this is really how we classify all of our women as screened in pregnancy. So kind of level 1, they don't have any risk factors. Level 2, they've got some risk factors. And level 3, they've got multiple risk factors. And it kind of guides us in their management in the pregnancy about doing regular checks, maybe doing some ultrasounds, maybe putting them on aspirin. So other ways we can screen apart from risk factors is something called preeclampsia screening. So this can be performed at the same time we do that early structural scan or that nuchal translucency scan. And this happens between 11 plus 0 and 13 plus 6 weeks. And it has a few components. It's been shown to be really effective. It was actually created by the Fetal Medicine Foundation. And there's some good studies, including the SPREE study, that kind of says we identify through this about 85% of women who are going to go in and have preeclampsia, early onset preeclampsia, or a growth restricted baby. And we've kind of put in all these factors. So we put in the medical and family history of the mum. We do multiple blood pressure management on both arms and we use the MAP. We do mum's height and weight. And we also do blood. So we do PAP-A and PLGF that are reflective of placental function. We also do a Doppler ultrasound of the uterine arteries. And what we're looking for is increased resistance or notching. All this kind of goes into a calculation to allow us to determine to the woman, are you at high risk, so more than 1 in 100, or low risk of developing preeclampsia or fetal growth restriction. If someone tests positive for this, then we're recommending low-dose aspirin, to commence low-dose aspirin to reduce these risks. So the risk factor-based screening I showed you just before identifies about 50% of women at risk. This is about 85%. The other thing is that not every centre is doing this. So this is where that first trimester screen, that nuchal transits, the early structural, where you go matters, because this is generally only performed at women's specific ultrasound clinics, because not everyone does those uterine artery Dopplers. It is just in the new RANSCOG guideline. It does actually talk about this preeclampsia screening if anyone wants to read any more about it. I think that came out in about April or so this year. So those women who screen high risk for fetal growth restriction, watch either on preeclampsia screening or on the risk-based screening, what should we do? Make sure they have an accurate dating ultrasound, because this is exactly how we work out if the baby is small or not, and preferably we're doing that less than 14 weeks. We here at the Royal have a policy as well about if it's discordant between their period and their dating ultrasound, exactly what dates should we use. But that's super important, and that's the first thing I do for every single couple that I see. The second thing is address any modifiable risk factors. There is good evidence that if the mum stops or reduces smoking, or also if she's an increased BMI and she doesn't put on a significant amount of weight, she can actually reduce her risk of fetal growth restriction in that pregnancy, which is super important. We want to be doing regular fundal heights. You can kind of see there's a little picture there. Super cheap, super simple. It does depend a little bit on who does it and what their experience is. We consider more than 3 centimetres is significant, and it detects around 30% of growth restricted babies. Not terrible, but better than nothing. And then we've got those growth ultrasounds. So serial measurements, like I showed you before, is the most helpful, and it really helps to plot them out. And with that, we detect around 85% of growth restricted babies. So still we're not detecting them all, but it's the best that we've got. And then always remember, refer if you have any concerns. We would much prefer to see women if you're worried than to kind of miss out because of all those important sequelae that we've talked about for identifying these babies. So someone gets sent to me. So this is a case we had a little while ago. Obviously the details have been changed a little bit, but essentially she's a woman in her second pregnancy. She'd previously had a 3-kilo baby at term, uncomplicated, and spontaneous pregnancy. She'd had that low risk NIPT and her early structural scan was normal. She'd had a morphology ultrasound, which was normal. She was now 29 weeks, but she presented because she was worried that her baby wasn't moving very well. So what we did is we did a growth ultrasound. And so the components of this growth ultrasound, the first thing that we do is we actually estimate how big the baby is. And the way that we do that is we measure around the baby's head, the head circumference, around the baby's tummy, the abdominal circumference, and then the femur length, the thigh bone. And this little, you can see right down the bottom there, it's a very complicated calculation on how to actually work out how big the baby is. The computer does for us. But again, you know, we're worried of growth restriction where the weight or the abdominal circumference is less than the 10th centile, or if there's been a drop. The second thing we do as part of these scans is we actually look for how much fluid is around the baby. And there's a few different ways we can do this, but usually what we do is divide the mum's tummy into 4, and we do 4 different pockets of fluid around the baby to give us an estimation of how much fluid is there. It does depend a little bit on how many weeks pregnant you are, about what's normal. But the reason we care about this is because if there's an impairment in the blood supply to the baby, it's going to affect its kidneys, and baby's not going to urinate as much because there's reduced blood flow to baby's kidneys. So that's the main idea behind this change in amniotic fluid, which is made up from fluid from the baby's kidneys. The next thing, and don't be put off by this, it looks very complicated, but the next thing we do is Dopplers. And in essence, we're checking 3 different circulations with doing our Dopplers. We do the uterine to check how the mum is responding to the pregnancy. We do placental, which is at our umbilical arteries, which is really telling us how is the baby responding to that placenta. And if that's abnormal, the risk of perinatal mortality is 4 to 10 times increased. So that's a really important risk factor. And the third one we're doing is actually looking at the fetus. And so this is in 2 different circulations. One is the middle cerebral artery, which is a little vessel in Bubby's head. And how I describe it to couples is that babies are very smart. They know their brain is really important. So when they're struggling, they open up their blood vessels in their head to send more blood up there. And that's what we call brain sparing, which is how we can tell this baby's getting stressed. And that's a really good prediction for if the baby's going to be acidotic at birth. And then the final thing we do is the ductus venosus. This is a special little shunt in babies, which really is telling us how that heart is working. And it's a very late sign for a very stressed baby. And we also look at other things. So the amniotic fluid that I talked about, echogenic bowel, which really just means when we're doing the scan, the bowel is looking a lot brighter. And this again has got to do with reduced blood supply to the fetal bowel. And we're also checking around the baby's tummy. So if we go back to the one that we got referred, so decreased fetal movements at 29 weeks. And the idea behind doing a scan at this point is to pick up, are these babies at increased risk of stillbirth? Because that's what we get concerned about with decreased fetal movements. Or is there any other reason that mum has noticed a difference? And we saw that this baby at 30 weeks was only weighing 1.1 kilos, so the first centile, with an abdominal circumference less than the first. And we plotted all the previous scans, and we're a bit worried because actually the baby's not growing like it should. So we are getting quite concerned about this baby. But there was normal fluid and there was normal blood flow patterns to the baby. So when we confirm a small baby, we then need to do some investigations to work out why. The first thing, as you saw before, of the causes of growth restriction, we do a preeclampsia screen. So we're asking the mum, do you have any symptoms? Do you have a headache? Do you have any visual changes, right upper quadrant pain? We do the preeclampsia blood, so we check her kidneys, her liver, her urine, her blood count, and we're also doing that protein check. We do an infection screen. The yield is actually really low. So there's been a recent article that was published that says it's probably only 2% of growth-restricted babies is because of an infection, but it's pretty easy for us to do. It's just a blood test for mum. So we just test CMV and toxo. The other ones don't really cause growth restriction. So these are the only 2 we need to do, but we order IgG and IgM. And Dr. Coogan kind of made a bit of a comment before. It's not part of a guideline yet, but I would be recommending that pre-conception, it would be really helpful to know what a woman's CMV status is, because the greatest risk if she gets primary CMV in the first trimester. So what we try and do is we do these bloods when we find there's a growth restricted baby, and then usually I'm the one calling up the lab trying to add on these bloods to the first trimester bloods to see, have we seroconverted in pregnancy? But often it's very hard to work out because a woman's IgG positive for life, and so I can usually not completely exclude it. So it becomes quite challenging. But if I know a woman's never has had CMV before, then I can be much more reassuring this is very unlikely to be CMV. We also want to do a structural assessment. So every woman we see, we redo the entire morphology ultrasound. And we also talk about an amniocentesis. So this is where it's a little needle under ultrasound into the mum's tummy. We collect some fluid from around the baby and we send off for genetic testing. In a structurally normal baby, the yield of this would be less than 5%. If we're seeing structural changes, then it would be higher, kind of up to 12 to 15%. So it really depends on what else we're seeing. But we routinely would talk with these couples that if you wanted this test, this is available. So going back to our case, so she had a normal blood pressure, her bloods and her urine were normal, but the infection screen, I couldn't really confirm that she hadn't had CMV because she was IgG positive, but it was thought to be very unlikely. And the baby was so small and it was dropping centiles, so it was unlikely to be constitutionally small. And we noticed really subtly the baby's eyes were a little bit closer together on scan. And she'd had like 3 external scans and no one had picked this up. So this is why it's also really important where women get their scans, picking up these really subtle features. And in this case, we actually we did an amniocentesis and we actually found the baby had an abnormal result, so mosaic for trisomy 16, which is very unusual, but it also gave us some options going forwards to talk to the couple about their options with regards to the pregnancy. So once we kind of work out the baby's growth restricted and we kind of can work out if there's any underlying pathology, then we need to manage them because there's no actual treatment for growth restriction. So really what we're doing is we're serially monitoring them with growth ultrasounds, Dopplers, and fetal heart rate tracers. And essentially we deliver when the risk of fetal death is greater than the risk of neonatal death. And we kind of try to optimise it as much as we can before the baby's delivered. The Royal here, we do have a good policy on how we actually monitor these babies. So it's really easy. You can just Google it. And it kind of defines it by early onset versus late and the investigations to be done. Also talks about when to refer them through to MFM. But as I've kind of just touched on that, all that for you at the moment. And then when do we deliver? There's some good trials that have great names like Grit and Truffle and Digitat, which you don't need to know about. But if you want to know a lot more, this issue or guideline is really nice reading about how we actually monitor babies with growth restriction. And it has this beautiful diagram I love and have printed in my office to kind of tell us about how frequently are we scanning and when are we looking at delivering. But we've also popped that in a table form in our hospital policy, basically. But again, it's really just where the risks of stillbirth is greater than the risk of neonatal death is really what it comes down to. So when we're kind of talking about birth planning, it really is shared decision making with the women and their families. It really, how we're having the baby depends on how many weeks pregnant we are, why are we delivering, is it mum reasons or baby reasons? Has she had any babies before? What's the cervix up to? But we always want to monitor these babies in labour because growth restricted babies are much more likely to get stressed in labour. Generally, if the baby's small, but the fluid's normal and the blood flow patterns are normal, we'll usually give her a bit of a go of vaginal delivery if we're kind of close to term. But if the blood flow patterns are abnormal, baby's got a much higher chance of getting stressed in labour. So we usually kind of say it's probably, 50, 75% for some cases. You may not want to kind of put baby through that. We always send the placenta for histopathology. It really kind of confirms the diagnosis. But also in a small number of cases, it can be related to placental structure, like a VU or a chive or these fancy other names. And that actually can change how we manage these women in a future pregnancy. So some of them, we actually put them like immunosuppressants and we do a lot more for them in a future pregnancy. It's pretty rare, but important not to miss. We are relatively terrible at chasing up our histopathologies, I would say, as a cohort. I've worked in many hospitals. I'm saying that for everyone that's here. So I think if you have a woman who's had a baby before that was small, if you have the ability to contact the hospital and look at that histopathology for the placenta, it might change the woman's care in a future pregnancy. So I know it's kind of annoying, but it might be helpful. The baby essentially gets monitored and the recurrence risk is actually up to 30%, which is reasonably high. You can consider commencing aspirin in a future pregnancy. The data around this is a bit varied. So most of the data on aspirin really has got to do with preeclampsia, but some trials have also looked at growth restriction. The overall risk of having aspirin in a future pregnancy would be low. So we usually kind of discuss with them more about what they want to do. And we absolutely would recommend growth ultrasounds in a future pregnancy. And usually we'd start a few weeks before the onset of the growth restriction in this current pregnancy. I think that's mostly what I had to talk about. Does anyone have any questions about any of that?
Online question. Is this on? Yeah. With aspirin initiation, is there a role for caltrate too?
This is very controversial. Sorry, so the question was, in addition to aspirin, should we also be giving calcium supplementation? So the data for this is relatively varied. So we previously always said we should recommend calcium supplementation for all women who are at risk of fetal growth restriction or have a risk of preeclampsia, and Aru might talk about it more. But essentially we say only if the woman has a low calcium diet would we recommend routine calcium supplementation. So it's not something that we say for all women because the data is somewhat varied. Dr. Coogan. Okay, sorry. Dr. Coogan's asked again about CMV serology. So my understanding is the guidelines have been altered in Australia recently that says that every woman in the first trimester should have a CMV IgG done. my argument would be you should do it prior to conception, because how can you exclude CMV in the first trimester if you're only testing them in the first trimester? So that's my argument for doing it prior to pregnancy. And so everyone's phones are going blind. And certainly in women who are at risk. So women who have a toddler or have healthcare workers or who have children in childcare, because over 60% of women have had CMV before. The serology is not going to tell you if they were 5 years old or 30 years old. So, and the risk, we should still be saying to all women, don't share food with your toddlers, don't kiss them on the mouth, because we don't want to get a reinfection of CMV. So we should still be doing all that, all that hygiene kind of stuff. But I think it's most helpful if they've had a pre-conception. But that is not part of a guideline. That's just my opinion.
The outcomes are not as bad.
So the recent data would say that if you get, CMV, we're most concerned about getting CMV for the first time in your life in the first trimester of pregnancy. The data would suggest that if you get it after the first trimester of pregnancy, the sequelae for the baby is really very minimal. So it's really those first 12 weeks that's so pivotal for not getting CMV. Does that answer?
And how much CMV take up in the end?
Significant. I would be seeing it at least every week. Yeah. So I think it's really good that there is a lot more information about CMV coming out. I mean, in terms of growth restriction, it's probably only about 2% of growth restrictions are because of infection. So I think that overall the yield is very low, but it's quite easy for us to kind of do the testing. We also can, in some situations, if the serology is confusing, we can send some of the amniotic fluid off for CMV PCR, which also tells us definitely, is there an infection going on there or not?
There's also another question online about CMV testing. Should IgG avidity be done as standard alongside CMV IgG?
So no. Pardon? So whether we should be doing avidity in addition to CMV IgG testing, I think is the question. So the avidity is really beneficial for telling us if it's a recent infection or not. The way that I like to think about it is that if you've only just met someone and you're becoming friends, you're not very friendly. So you kind of got a low avidity, like the low on your friendship circle. If you've known each other for a long time, you're going to be really good friends. You're going to have a high avidity. So a high avidity is very reassuring. The infections happened some time ago, more than 3 months ago. But I don't think it should be retained, because if you're doing it pre-conception, you're just proving it's you've had it before the pregnancy. Yeah, but we do it in a pregnancy if we're trying to work out exact timing of it. It's very murky. It's very confusing for everybody. Okay.
Oh, no. So we have a positive CMV IgG.
Yes.
There is a chance of reactivation.
Yes.
How dangerous is that?
Much less than getting primary CMV in a pregnancy. So what we generally say is that if you were to get CMV in a pregnancy, so if you get primary CMV in the first trimester, 30% there would be mother to child transmission in 30% of cases. Overall, 10% of babies would be affected by CMV, so about a third. So then when you're kind of looking at the reinfection reactivation, I think it's like 1 to 2% would actually, mother would get CMV in the pregnancy, and then a third of those would be affected, babies would be affected, so it's much less significant.
This is evidence, so people can provide some reassurance, because it's confusing and it's changed a lot in the last month or so.
Yeah, it's very confusing.
Very social media.
It is. That's why I think just having a pre-conception CMV so you can reassure people you've had it in the past, the likelihood this is going to cause any problems is very low, because we really care most about primary CMV in the first trimester.
Should they be screened for parvovirus?
We wouldn't routinely. So parvovirus, the greatest risk of parvovirus is fetal anemia and fetal loss. And so overall, the risk of that would be quite low. Women can generally, over 6% of women have had parvovirus before. So it's usually when we know that there's been exposure that we would start doing the testing and serial surveillance. So it's not routine recommended unless there's we're seeing features on ultrasound or mum's had known contact.
Recommended to add that to the agenda, because we don't know that. We test only when we run.
Yeah. So, I mean, I guess if you go to the same ultrasound, if they have the scans at the same ultrasound clinic, they generally would plot it. So they should be able to tell. I mean, you can roughly look at if the baby was 90th centile now and it's 40th, like you can kind of do those numbers yourself. I think in our hospital guidelines, there. Oh, the SFH. Yeah. Yeah. Plotted. But I think that, yeah, the general rule for fundal height is 3 centimetres different than the gestational age, basically. Yeah. But I think there is for the ultrasounds, I think in our hospital policy, there is a plot, the fetal growth at one of the appendixes.
Then you would be able to see it. So that this is
And at this point, we're doing population growth charts. We are not doing customised in Australia, in New South Wales. Correct. Yeah, we're just doing population based.
3 kilo baby for a healthy Somali woman probably big breasts.
Yeah.
Yeah, absolutely. So the UK would do the customised, but in Australia, New South Wales Health has decided not to use that.
Some more online questions. Should we do toxoplasmosis IgG?
About infection. So the risk of, the risk of toxo is also very, very low. Again, the toxo you get is generally if you do not wash your hands after changing cat feces. If you wash your hands, you are totally fine. You're allowed to play with your cat. My husband's a vet. He gets driven insane by people asking them to put down his cat because they're pregnant. So just tell the women, wash your hands after you change the cat litter. But the main source in Australia is actually like fruit and veggies. So not washing your fruit and veggies properly because it's the soil's contaminated, or undercooked meats. So if you're kind of doing the food hygiene in Australia, we've got some really good guidelines. You really shouldn't be getting toxo. And toxo we would see extremely rarely in Australia. It's much more common in countries like France and Spain when they do routine, in Italy they do routine toxo serology there. We don't do it here. So I'd say the risk of toxo in Australia would be very low. I just can't remember the numbers off the top of my head.
And if you have lupus, should you be on aspirin as soon as possible?
Aru, I'm gonna give that to you. I think it's probably going to be part of Aru's talk. Who's next? Or now she's going to make it part of her talk. Correct. Yeah. Yeah. So category 3 up here. So that is for true lupus, not just lupus antibody positive. Correct. Yeah. And that was only updated. That's from October. That's the new one from October this year.